What's up, party people? My name is Sunny Ray. This is the Sunny Ray Show. I'm back again with this is, I think, our third interview for the day. I've got a really, really interesting gentleman on the show. His name is Patanjali. He was actually, believe it or not, one of Geoffrey Hinton's earliest students. He's a remarkable fellow with a really, really interesting career. We're going to talk today about Fourth Vital, an AI native upstream kidney risk intelligence platform combining non-invasive edge biosensing with longitudinal AI to detect physiological kidney decline before conventional lab symptoms or crisis. I'm going to bring on Patanjali. How are you, sir?
Hi, Sunny. How are you doing? Thanks for having me today.
Yeah, I'm great. I'm well. I'm excited to be chatting with you. Where are you calling in from?
Calling in from Turkey currently.
Turkey, all the other side of the world. So, but potentially tell me what does Fourth Vital do, and why should the audience care? Why should people tune in?
So, a lot of people don't realize how big of a problem kidney disease is until it's too late. In fact, close to 1 billion people in the world have kidney disease, but they often have no idea until things get really desperate and, there aren't very many choices left. And part of the reason is there are no symptoms until it's late stage. And the current methods of detection detect the disease far too late. And primarily routine labs, extremely useful. But I lost my mom to this, and I was like, there's got to be an earlier signal that can actually detect kidney decline earlier. And I determined that there was earlier research done on physiological signals that detect kidney decline earlier. And Fourth Vital, for the first time, is bringing this together in an easy-to-use platform using a edge data capture system that's basically our data collection layer combined with our AI signal that's very unique, which is the business essentially. And so we're really excited by that because this is really going to help us take a lot of these folks, 90% that are undiagnosed, and actually be able to diagnose them much earlier and stratify them. And this is huge because physicians having the opportunity to intervene earlier mean it's really life-changing. There are many things that they can do which they can't today. And I really don't want to see people suffer in the way my mom did, and watching that as a loved one is really difficult. And I think we have a chance here to do something that can really benefit a lot of people. The disease is getting worse by the day. I talk to physicians around the world. Health systems are overburdened by the cost. It's incredible. $1.6 trillion a year just to treat kidney disease, cardiometabolic, renal disease. So these are all the related areas for kidney disease. It's incredible. And all of those have bad outcomes. So it's not like we're spending a lot of money and saving lots of lives. We're just dealing with their end-stage renal failure. So lots of reasons why we should care about this. And I really appreciate you bringing me on your show because I think a lot of people just need to know about this because, 1 in 7 people have it. And it could be somebody sitting right next to you and you wouldn't know it.
I think health tech, longevity. I mean, I think even Y Combinator's recent list came out, right, where they listed this as like the #1 priority of applying AI. So I gotta ask you something. So, but then let's maybe slow this down a little bit, back up. So, in the pre-interview, you mentioned something that was really interesting. I gotta ask you. So, what was it like learning directly from Geoffrey Hinton, and what idea from him still shapes how you build today?
Yeah, it's really interesting, right? I did my undergrad at the University of Toronto in computer science and AI, before anybody even cared about AI and anybody really cared about Professor Hinton. And I really feel blessed to have studied with him and Dr. Robert Lockhart and several other luminaries, Professor Ron Becker and so on. And, in those early days, the real impetus for AI was really about understanding if we could computationally represent the human mind and the human brain in a way that we could understand it better and basically by understanding it better, we could solve some of the challenges and also figure out how we can use our minds, more effectively, right? So this is really the motivation. And really from the early days, in my earliest courses, I remember Professor Hinton really talking about, he literally always believed that the true promise of AI was in healthcare and that this is a real opportunity to make huge impact. And I think still today, if you ask him, he talks about the fact that this is really the #1 area that AI can have the biggest benefit. So I feel blessed to have been in those early conversations and with, really trying to understand how to get there. And now I'm kind of circling back after years working in as a designer and an engineer in companies like Oracle, Microsoft around the world. So I'm really it's interesting that I'm circling back to that. But those early days were really something else, when people were very skeptical about what was, even my mom was very skeptical. She was actually really upset that I went into AI. So, it's kind of interesting, unfortunately, that my mom passed away and now I'm using AI to actually detect the disease she died from much earlier.
You mentioned that you'd worked 12 years at big companies like Oracle and whatnot. So what took you from enterprise software into kidney disease specifically?
Yeah, I mean, look, the motivation was losing my mom and realizing that something needed to be done. It really became a passion project. I spent years studying this, trying to understand as much as possible the causes of kidney decline and how it can be detected. And so that was really the core motivation. And really, my background has been for decades in building large, complex, and designing enterprise systems that deal with large amounts of data and being able to figure out what to do with it. And that's really the expertise that I've carried with me, and my team, who've all either worked for me or worked with me, have a lot of experience in this area. And now we're basically applying those same principles to kidney disease, and basically trying to do something that hasn't been done before, is to bring it together in a way that physicians can use it and eventually patients as well, in a simple to use interface, and provide the data, the insights in a very simplified way so that physicians can actually make decisions. And so all of this coming together is really a culmination of everything that I've done in my entire career.
And then you added an MBA from Columbia, right? Focused on finance and venture on top of a computer science and AI degree from University of Toronto. How did that combination shape the way you think about, building a company in a regulated space like health tech?
Yeah, actually, I actually ended up with two MBAs, one from Berkeley, Haas, and from Columbia. Is a special, we call it a limited edition dual MBA program. Had to do exams in both coasts, so very exciting. But honestly, I had not studied finance in undergrad. I had the opportunity at U of T, obviously great finance program as well. And at some level, there was a level of curiosity how to bring all this together. And I learned a lot in the program, not just from these amazing professors in areas that I'd never studied before, about truly how to bring something to market and how to do it at scale. But the team, the people, my classmates, many of whom are involved directly with Fourth Vital, including on my board. And so really my business school education that happened much later was pivotal in being able to start Fourth Vital, and learn from a lot of folks with a lot of expertise in this area. And this is a complex space. Enterprise software is very complex. But when you start to bring all of the data elements together along with medicine, it adds another layer of complexity. And interestingly, University of Toronto gave me a really strong foundation because our undergrad program was highly interdisciplinary. And now I have the tools from business school to actually bring these things together and apply it to execute.
Your Fourth Vital sits at this intersection of biosensing hardware, AI, and clinical medicine. So which of those three was the hardest for you personally to learn, coming from a product and UX background?
Yeah, I mean, to be honest, to really understand, on the medical side, right, what's actually going on, getting literally deep into, the causes as that we know of or that we don't know of kidney disease, and what actually happens in the body. And I think that curiosity, started in those early years of studying AI, where we crossed a number of these areas. But I was fascinated by the fact that, look, I know that the body, we're 60% made up of fluid. In fact, everything in our body are sets of bioelectrical signals. So it's actually not a far stretch to believe that there are signatures in the body that are being given out. And so my hypothesis was, I wonder if we can trap those signals. I wonder if anybody's actually looked at it closely, then use the data from those signals to actually bring together something that actually addresses this in a very unique way. And that's basically what we've done. And I think there's huge opportunity here to take this even further. And I believe we're in the early days of understanding what the stories that the data will tell us, and allow us to really understand what we can do here even more, even beyond kidney disease, in fact.
And potentially, before you had a product, what did the earliest version of this look like, and how far off was it from where Fourth Vital is today?
Yeah. So we kind of have two pieces of this. One is the edge data capture layer, which is basically a device just for data collection. And I discovered there wasn't anything that was exactly doing what we needed. There were other FDA devices that were close. And so we actually ended up building that. That was actually probably really hard to do, but we did it in a very short time with an amazing team of engineers and one of my board members who's an expert in this area. And that, I would say, initially was very, very hard. And that is still something that we're developing now. And part of the reason why we're in Turkey is to actually develop that research use only data capture system for collecting more data from clinics around the world. And so, that was one part. And Fourth Vital Clinic is the software. The software is still being used to collect data from a top kidney hospital in Canada. And it's the same software that's actually available in 7 different languages, HIPAA compliant, that we'll use to collect data from other clinics as well. So as we collect data, that software actually evolves when we start to get into the AI layer to actually start to show insights. So I see huge opportunities for innovation there itself, but really the hardest part initially was getting this edge data capture system. We actually used kind of modern IoT sensors. We've patented some unique methodologies there, and allowing patients to do it remotely from the home very easily. And that was really a goal. And that's where my design background really comes in, which is how do we bring this all together in a way that's really easy for both physicians to use and for patients to use.
Got it. Interesting. Potentially you've said that the science behind physiological fluid shifts and kidney risk already existed in the research literature. What was actually missing before Fourth Vital in your view, and why has nobody closed that gap?
It's really amazing. The research stretches back over 35 years ago. And since then, there's been a lot of research based on those initial papers. And, I dug into this. I even talked to some of the original paper authors to understand why wasn't this mainstream, right? And what I discovered is that their solution works in research labs, but is basically unusable for physicians and certainly not patients. So I'm like, nobody has actually looked at this from an engineering perspective and said, and design perspective, how do we bring this together, right? And by bringing it together and making it easy for physicians to adopt and for patients to utilize it, I think that was the missing piece, right? So commercializing something that sat in research labs that only a few research scientists in the world actually can use and do use, and it wasn't pervasive. But the paper since then, I mean, very recently, I've gotten in touch with several research scientists that have been working on understanding how these signals can actually detect the kidney decline before existing methods. And really, even the most recent papers are very profound in that. So we know, and the feedback from them as well is like, we have something very unique here. And so I'm really excited about bringing all this together, probably more excited about getting our hands on all the data where we can actually start to see the patterns where I think the real potential lies.
Combining, I guess, this like non-invasive edge biosensing with this longitudinal AI is a very different architecture from a single point in time lab test. So what was the hardest technical problem in making a watch over time model actually work?
Yeah, I mean, the signal engineering is a bit complicated, and we're still raising capital to build the EVT, but our working prototype, that was probably one of the hardest things, getting the signal to capture with our unique strip sensors. That, from an engineering standpoint, was really, really challenging. And I think we've kind of overcome some of those initial challenges. I think moving forward, turning that into something that can be used and it's viable, right? I think that'll be the next challenge, right? Getting that and scaling that up. And so that's one. And, I would say it was very interesting because I didn't realize, not being a physician, how what we were doing had benefits across the spectrum of kidney disease. I'm thinking about prevention. And, we're still away from that. But what I recognize is that with close to 1 billion people with kidney disease and 90% not knowing it, detecting kidney decline earlier is actually a big goal. And today, the routine labs, we're complementary to those labs. We don't replace that. But the labs provide a level of detail and signal about what's going on. But the physiological changes in the body happen before they show up in labs. So by tracking that earlier, it opens up huge avenues for earlier detection of progression in a larger, and being able to measure people from the home, people who are at higher risk. That's huge, because today it doesn't happen because it's very complicated. And so, so that kind of gives you an idea of how we're thinking about this.
Yeah. And potentially you now have live IRB approved data collection running with real patients at a kidney unit in Ontario, like you mentioned. So what had to be true technically and organizationally before a clinical site would, let you in the door?
Yeah, what's really interesting in this, I know for a fact, trying to do this in the United States, there's a lot more hoops to cross. And it was actually surprisingly much easier in Canada. And I think part of the reason is the research unit that we're partnered with was very motivated to try to get this into their system and start actually collecting data for us, because they found value already with the software that we had created. And so what was interesting is that a lot of the things that I would have had to handhold in the US at great cost and great time, the hospital, the clinic, they all were able to get us through the IRB, and we didn't have to deal with a lot of those complexities that in other parts of the world really, really complicated. And, honestly, I'll tell you, it's a testament to, I know that the Canadian healthcare system sometimes comes under a lot of scrutiny, but to be honest with you, if you look at the core of the motivation around trying to reduce the suffering of patients, trying to keep patients in the home longer, how can we solve this, and also save money at the same time, that motivation gets people to try to help get all the ducks in the row, right? So I really think that all of these coming together was something unique, and we're hoping to replicate that same in other parts of the world as well, and eventually also the US. But the US, being a for-profit medical system, it's a bit more complicated, right? And dealing with insurers and things like that. So, I would say that it was far less challenging than I expected, certainly compared to the United States. I think Canada is really a great place to do this kind of data collection.
Really interesting. So what's one of the most surprising thing that you've learned so far from like working directly with the physiological data itself? Something that you maybe didn't expect going in?
Yeah, so it's really funny. I've pivoted the startup a couple of times. I first, took a very device-first approach, right? And I basically realized that that's actually not our core business. And introducing that at the top end to investors, not being a medtech entrepreneur, expert, didn't, added a lot of risk to those investors, right? And so I learned that. And then I later pivoted to an AI data first play when I recognized, and this was the surprise, that the software that we had, the signal that we were using, and the way that we were representing it was really useful today in clinic. I hadn't even thought about existing kidney patients, to be honest, initially. I was thinking about where we really want to go, right? We want to go to prevention. We want to detect patients who don't have it yet. I didn't realize how big that problem was. That was an eye-opener. And basically, sometimes it's like this, and I've learned this in my career. I think as engineers, computer scientists, we come up with ideas about how to solve certain problems. But honestly, until you put them in front of real users, in which this case are physicians, and get them to give their feedback, you really don't know if it's the right thing or just what you're thinking. And not being a physician who's dealing with this kidney disease day in and day out, there's no way for me of knowing that. And that I learned that surprisingly. And as we move forward, I recognize that signal itself is very unique that we're leveraging in our models. And so downstream kidney platforms are interested in leveraging what we're doing. So that was a surprise, because I'm like, why would you want the signal without the AI to start with? Research teams want that signal. So we're using that to basically collect our data. And that's really the story that we've ended up, the trajectory that was not initially in our plan at all.
Yeah. Hey, you said you're building inside essentially a category like cardio, kidney, metabolic disease that you've
Yeah,
put around $1.6 trillion a year globally. How does a
yeah,
company your size decide where to focus first inside of such a large
yeah,
problem?
right. Yeah, I mean, look, as I said, we kind of pivoted a couple of times on the focus. And what I recognize is that if we can stratify these patients earlier upstream, that gives physicians a way to intervene earlier with existing patients with kidney disease today, right? They've crossed that line of scrimmage, as we say in Canada, they can't go back. And once you you're diagnosed with kidney disease or you have it, it's irreversible today, right? So, that basically, I would say, is kind of, where we kind of ended up going, which was not our initial plan. And I think it's also where we can get Fourth Vital adopted, right? Because being able to stratify patients earlier, in the United States, there's something called value-based care. There's incentives for physicians and clinics to identify patients earlier with risk and intervene, and that's big. And so Fourth Vital sits at that point, not only in the U.S. healthcare system, but around the world, right? Healthcare systems around the world, systems like Canada, which is a national system, it's really important to not only reduce suffering, but reduce costs, right? And that $1.6 trillion adds up very quickly because there are so many confounding comorbidities related to kidney disease. And really, people don't realize how interconnected the heart and the kidneys are. That's something that I learned, as I was going through all this, that I didn't realize, that how closely related those organs are. What happens in the kidneys often gets reflected in the heart and vice versa. So there are so many other diseases that are in this class of cardio metabolic renal disease that combined that are at higher risk. So we can actually, if you look at that $1.6 trillion number, it literally combines all those areas that are directly related to kidney disease. And so how we decide to focus is making sure we're focusing on one problem effectively at a time. So we've kind of refocused, as I mentioned, into patients existing with kidney disease, and we're actually starting with stage 5 patients, because it turns out that the signal, we learned this from the London Hospital, is really helpful in dialyzing patients as well, because they often have complex fluid issues. They end up with, unfortunately, patients suffer a lot. Dialysis is it's not a very comfortable experience, and patients often die as well. So starting with that and moving back to stage 1 allows us to basically, tackle that area of this $1.6 trillion. It's really the majority, if you will, right? But starting with that and moving backwards, and again, I think it's really important. This is, I think, a lesson for all entrepreneurs. You have to start somewhere. We have to listen for the stories. The data tells us stories. So you need to get the right kind of data. It's not just the amount of data, it's the right kind of data, right? And, the thing with data scientists is that data scientists know how to find the answers. They don't necessarily know what questions to ask. So you need to bring those two things together. And by asking the questions directly related to patients that already have kidney disease, then that really also gets the data scientists starting to think about, well, how do we bring all this data together in a way that's understandable, that's useful, right? So going after this once, the number is huge. So you can't look at it and say, we're going to go after 10%. This is, to me, ridiculous. You have to go where the data tells us the problem is, and where we can easily understand what's going on. And that's how we're approaching it.
Awesome. Thank you, Patañjali. Awesome interview. We're at the end of our time here, just a minute over, but you've been very gracious. Thank you all for tuning in. Until next time. Hang out for 1 minute, Patañjali. I'll bring the stream. Thank you.